So thanks for having me. I'm glad to be here. So I'm going to be talking to you about vascular robotics. A lot has changed in vascular, percutaneous vascular treatment in the 40 years since Andreas Grunzig performed the first PCI in Zurich, Switzerland. Why has it become more sophisticated? Balloons more trackable, stents are more deliverable. But while devices have evolved along the way, the procedure itself has remained unchanged for the most part from then until today. The fact is the physicians are still standing there, wearing lead for a prolonged period of time, being blasted with radiation, leaning forward, looking across a patient at screens, and trying to make judgment calls on various lesion lengths and things like that, and make small, precise movements with their hands. The reality is no two physicians have similar skills, and so there's a wide disparity of treatments throughout the world when it comes to peripheral vascular, PCI, and neuro. So what does Corindus bring to the table? We provide the opportunity by bringing a robot between the physician and the patient to move into various different segments of technology. This is our second generation system, CorePath GRX. It has been optimized really to be able to handle more complex and simple cases. There are two main parts to the system here. There is the bedside unit, which consists of the extended reach arm, the robotic drive, and the bedside touchscreen. And then over by the physician is the interventional console, where he has a screen comfortably in front of him, joysticks, doesn't have to wear lead, and has a lot more comfortable position for throughout the case. The system is able to adjust one guide wire, 014 rapid exchange, one balloon or stent, and one catheter at a time. Our system is device agnostic, so we don't make the disposable portion, and we're also imaging system agnostic as well. So some of the benefits that our system provides to the user and the patient are, extreme precision. The ability to move devices a millimeter at a time is exceptional. It makes a big difference in very specific applications throughout the body. Also, of great benefit is our measurement tool. So you can use our measurement tool to measure certain lesion length, and it helps with reducing longitudinal geographic miss and stent utilization. Also worth mentioning is our safety feature. So we have a maximum force limit on our system. If a wire is pushing against the side vessel, the wire is not going to push and perf and penetrate. The wire itself will reach its maximum force limit, and the system will tell you to pull back. It's almost like autopilot on an airplane. I think the future in many aspects of medicine is going to be having like an autopilot system along with the physician to help against human error. And I think that's going to be a great benefit as we evolve our system. So, our system initially started as a coronary-based system. In 2012, we came out with our first generation system. And then, 2016 with GRX, our current system. We've done around 7,500 cases in the coronary area with CorePath GRX. We have FDA and CE approval for PCI and peripheral vascular medicine. We also, as we evolve over the last few years, we're looking into the neuro space, and we're moving in that direction in parallel with the peripheral vascular and the coronary area. And we've recently developed our hardware and software to be ideal for the use with microcatheters and some of those vascular, the neurovascular components. So we're able to get into that area. Long term, what we're planning to do is come up with our third generation system. That system will be focused really with the ideal for stroke treatment. And then, as you've probably heard with Corindus, remote treatment is the end game. The opportunity for us to treat patients with these emergency type procedures from a distance is going to make a big difference to patients throughout the world. So some of the clinical evidence that we've found to really support our system is, so a few examples would be, 95% reduction in radiation exposure to the physician, which is significant. 99.1% clinical success with complex cases, showing that our system is absolutely viable for a true robotic program where you can use the system for almost every single case. And then most recently, Dr. Tejas Patel at Apex Heart Institute in Ahmedabad came up with some significant data showing a 20% reduction in radiation exposure to the patient, which makes a huge impact. So when we look specifically at vascular treatment, our partners, our physicians have done many different cases, from SFA, below knee, renals, mesenterics, some carotid and subclavians. As I mentioned a few minutes ago, our neuro system has a different cassette with a different setup and allows us to get into the over-the-wire microcatheter systems. And so that'll allow us to get into a more diverse approach with CLI and also peripheral embolization products as well. So where do we go from here? What is the outlook, and both short-term and long-term? Well, first things first, platform development. As I mentioned, we are able to control one wire, one device, and one catheter at a time. So as we develop the platform, the idea would be to be able to control multiple wires at a time, multiple devices at a time, be able to do over the wire in addition to rapid exchange. So as it comes to automation, the reality is, as I mentioned earlier, there is a wide disparity of skills out there. And, there's a lot of time and procedures taken with just trial and error, trying to get the wire to go where you want it to go. And so we realized that if we could create some specific algorithms and take some of those wiring skills from some of the best physicians in the world and calibrate it, put it down into our system so that with the touch of a button, a physician could benefit from such and such as spin technique or somebody else's wiggle technique. I think we could ameliorate the treatment of vascular medicine overall, and in doing so also make things more efficient and reduce radiation exposure to the patient and all the other things just by speeding up wiring time. So some of the benefits of automation would be that. Some of the areas that we're working on, initially we came up with our first one in 2018, Rotate on Retract, with which we've had great success. We were able to show a reduction in wiring time by 53%, which is very significant. We're moving now. We have 4 more coming out in the next, before the end of the year. These include spin, wiggle, dodder, and constant speed. And the various different directions we can go in with automation is significant, not just device manipulation, but also navigation and that sort of thing. So it's an exciting time to see where we can go, especially considering we were able to reduce wiring time so significantly with just one automated movement. Next will be remote. And I'm sure you've heard of our remote success in India today. It was newsworthy. The reality is that remote is a hot topic in vascular medicine, specifically in certain areas where emergency care and quick treatment is key. So, that would be STEMI, which is where we put a lot of effort, and also stroke care. Everybody knows that the faster a patient can get to a physician and be treated appropriately, the better their outcomes would be and the survival rate. And, the reality is there is a shortage of physicians out there in the world, and there are a lot of people who have very little access to appropriate treatment to improve their survival rates. So our strategy is really to develop a system that would enable physicians and hospital systems to have hub and spoke model, where they would have treatment centers or their core team in one place and the ability to train people or treat people in various different areas. When you really think of it, the CorePath system has been a remote system since the outset in 2012. When you look to the image to the left, the hardwired 8 foot from the patient, that was just a wire that connected the physician to the interventional cockpit. The second image here shows Dr. Fajadeh at Clinique Pasteur in France. He decided to put his console in the control room, so he has access to a lot more information and his imaging tools and that sort of thing. And then next image along, Houston Methodist, they were able to use our console and create more of a power station where they were able to control multiple rooms so they can switch. We'll treat one patient, switch to the next, switch to the next. And that's more of an efficiency opportunity. What could we do using robotics to speed up turnover and to treat more patients? And lastly, the opportunity there is to be able to treat, patients from one facility to the next. As I mentioned, you could treat one hospital to the next. You could create smaller treatment hubs in various different rural areas. The opportunity and the variety of alternatives are endless. As you probably heard in the news, Dr. Tejas Patel in Ahmedabad performed our first in human cases in 2018, in December. He was 20 miles away in Akshardham Temple. We did 5 LAD cases. I think of note, the most important thing is that there is no latency. That's key when it comes to remote treatment. And we've invested a lot of time and energy into making sure that there is absolutely no latency, and that's with a variety of different internet connections. The cases all went very well, and there was really no time penalty. The average time that an LAD procedure would take was around the same as that remotely. So there was no impact. It was just a matter of reaching out to more patients in a shorter period of time. So, last but not least, worth mentioning, prescriptive analytics. The opportunity with our system is also that we could use cloud computation, that we could use that for prescriptive analytics, taking data of the thousands and thousands of patients that we'll inevitably treat. And so we'll have a cloud that would allow you to grab data and pull down and make recommendations based on lesion morphology, based on the tools that were used in similar cases in the past, and provide a treatment option and treatment recommendation that could or could not be taken by the physician. And then lastly, using navigational, the opportunity is to be able to point and shoot using the corresponding co-registration from diagnostic procedures. That's a great opportunity to be able to use that cloud computation for that as well. So thank you so much for your time. It's an honor to be here, and I wish all of you a wonderful rest of the convention.
Thanks, Joe. This is an excellent view of digital technologies and its relevance in how you can potentially reduce cardiovascular disease burden. So our last speaker here is Dr. Khanna. Over to you, sir, to talk on iCat suit.